Hello everyone. My name's Ray. I'm a medical student at the University of Exeter Medical School, and this is part 2 of the 3 webinar series I'm covering liver pathology. If you'd like to see some of my other colleagues' recordings, please click on other videos on this channel, and also make sure you check out the last part of this webinar series, which will be available in the description as well. And don't forget to like, comment, and subscribe to the Medics.Academy YouTube channel, and stay alert to our new content because we're constantly updating as well. And finally, if you're a medical student, do feel free to sign up to the free SDocs program, which you can do so from the link in the description. Right, so this is part 2 of the webinar series about liver pathology. So let's begin. So last time we've covered liver anatomy, liver functions, interpreting liver function tests, and fatty liver. Today we're going to talk about liver cirrhosis and cover hepatitis A as well as a bit of hepatitis B. So to start with, here is a question, a multiple choice question. I'd like to have a read of the question and think of an answer. Right, so the question asks, which of the following is a complication of liver cirrhosis? And the correct answer is E. So if you chose primary biliary cholangitis, then you're correct. All right. So I'll explain why E is the correct answer in a minute. So we're going to talk about liver cirrhosis, and I'm sure you've heard this term quite a lot. But the definition of cirrhosis is actually when normal liver architecture is converted into abnormal nodules and scar tissue affecting the normal functions of the liver. And cirrhosis is characterized by fibrosis, and progression can occur over weeks or years, okay? So it can be very fast or it can be very slow, depending on the individual extent of the disease. And then fibrosis causes distortion to the vasculature of the liver, leading to portal hypertension and esophageal varices or liver failure as well. So there are 2 types of liver cirrhosis, in fact. We have compensated and uncompensated. So compensated means that the person is systematically well in the presence of cirrhosis, and uncompensated means the patient is showing signs and isn't coping very well. So this is just an image showing the difference between a normal healthy liver and liver cirrhosis. So a normal liver should be smooth, have a smooth surface like this, but a liver with cirrhosis would be scarred, okay, and has fibrosis there. So in terms of causes and risk factors, I'm sure alcohol would be the first one that comes to mind, indeed, which is at the top of this list. But there are many other causes as well. So hepatitis, which we will cover today, and the next part as well. And then obesity, type 2 diabetes, non-alcoholic fatty liver disease, which was covered at the last part, and some conditions such as autoimmune liver disease, genetic conditions as well. Chronic medication usage, particularly hepatotoxic drugs such as methotrexate, and then Budd-Chiari syndrome or other veno-occlusive diseases, diseases that would form granuloma such as sarcoidosis, congestive heart failure, syphilis, and some risk factors being old age, being male, hyperlipidemia, and hypertension are all other causes of liver cirrhosis. In terms of presentation, Cirrhosis is generally asymptomatic, just like fatty liver disease, which I covered. But you can have non-specific symptoms such as fatigue, malaise, weight loss, and some nausea as well. Now, in terms of other presentations, the signs would depend on the extent of the disease. So you can have ascites or edema, so swelling, distortion of the abdomen because of fluid, and edema as well because of fluid overload, and caput medusae as well. So caput medusae is actually a liver sign, okay, with distorted veins that resemble, if you're familiar with Greek mythology, you would know Medusa with the Gorgon with snake-like hairs, and that was how this sign was named. And also jaundice, yellow tinge of the sclera and skin as well. Spider nevi, which is shown in this diagram. Telangiectasias as small blood vessels forming on the skin, and bruising, pulmonary erythema, red palms, finger clubbing. So you ask the patient to do this. So if you can, just to look at the little diamond space there, or you can ask, or you can have a look at the fingers like this. And then hepato or splenomegaly, and as well organ enlargement. And then you can have asterixis, which is a flap, what they would say. So a lot of you might be wondering, it's very difficult to tell the difference between a liver flap and a flap because of carbon dioxide retention. So this is a very useful clinical bite. So just see my arms. So as a general rule, a liver flap is subtle and asymmetric, like this. And then a symmetric flap is usually a sign of carbon dioxide retention. All right. So that's a bit of a helpful tidbit when you're on the wards. Now, in terms of how you diagnose liver cirrhosis, obviously it's difficult because most patients are asymptomatic. But if you suspect cirrhosis, then you would do liver function tests, and you would have elevated ALT and AST. If you remember from my last part, you would know that ALT is an indicator of hepatocellular injury. And so an elevated ALT level means just some sort of injury to the liver, and that's pretty much what cirrhosis is. And hypoalbuminemia, which you will remember from my last part, the liver synthesizes albumin, and having a low albumin would mean that the liver isn't functioning properly. And then we can also have anemia as well. And then you would also do urea and electrolytes, coagulation screen, because remember the liver synthesizes clotting factors, and ferritin, having a look at iron storage as well, viral serology, and then CT or MRI to look at the extent of the disease. All right. The NICE guidelines also mention offering transient elastography, which is this fancy looking device there, also known as a FibroScan, okay, in hepatitis C infection, high risk alcohol consumption, and alcohol-related liver disease. All right, so FibroScan is a very painless and non-invasive procedure that uses elastowaves to measure the extent of liver damage. So patients are very pleased usually pleased to do this procedure because it's painless and non-invasive. By the way, when we're talking about high-risk alcohol consumption, we're thinking for women more than 35 units a week, and for men more than 50 units a week. Okay, that's high-risk alcohol consumption. Otherwise, if the patient is not suitable, or FibroScan is contraindicated, then we would refer the patient to a hepatologist or gastroenterologist for assessment. Now, there is the CPT classification system of liver cirrhosis, and I've included it in this nice summary table right here. So basically, we do a scoring system, and we have a look at some parameters, including albumin, bilirubin, INR, ascites, and encephalopathy. Okay, and depending on the parameters, we score 1, 2, or 3 points. All right, and so obviously, the more points the patient scores on the scale, the more serious extent of the disease. Okay, and as indicated in the table below, when the patient scores 5 or 6, they have a higher life expectancy of 15 to 20 years. But when the patient has a score of 10 to 15, then life expectancy would be 1 to 3 years. Okay, and considering perioperative mortality, it would increase from 10% to 80%, okay, depending on the severity of disease. So personally, I don't think you need to memorize this classification system, but I think this is just something to be aware of when you're talking about cirrhosis and the extent of the disease. In terms of management, well, unfortunately, cirrhosis is generally irreversible, okay? But we can manage the condition as much as possible and reduce the risk factors. So immediately refer a patient to a specialist for anyone who develops decompensated cirrhosis, because they would be unwell and require admission. Treat the underlying cause as well. If the patient has hepatitis, then you would treat that. If the patient has diabetes, you would manage that with a diabetic team. If the patient is dependent on alcohol, you would refer to specialist alcohol services such as Alcoholics Anonymous or special clinics or even psychiatric services. Of course, lifestyle is important, so diet and regular exercise as well. But if the disease is late at end stage, we would consider referring to a local palliative care team when they require symptom control or palliative care, especially if they only have up to 12 months to live. Now, liver cirrhosis is very serious, and if untreated, it would cause portal hypertension, esophageal varices, encephalopathy, infections, and carcinoma, as well as cardiomyopathy. So cirrhosis is very serious, and we should do our best to manage the condition. Okay, so that's what I want to talk about cirrhosis. And so moving on from cirrhosis to a rather large topic, which is hepatitis. So here is a question on hepatitis to start with. I'd like you to have a read and think of an answer. All right. So this question would be tricky if you're not too familiar with the individual types of hepatitis. Okay. So for this question, the correct answer is B. Okay. And you would know why that's the case as we talk about hepatitis. However, I just remembered that I haven't gone through the correct answer for the last question. So for this question, the primarily biliary cholangitis is not a complication of liver disease. It's actually a cause, okay, of cirrhosis. All right. So the others are complications, but PBC is a cause. All right. So we are going to move on from liver cirrhosis to hepatitis. All right. So hepatitis, hepa meaning liver, itis meaning inflammation. So hepatitis is inflammation of the liver. So in terms of causes, again, there's the virus and alcohol, which everyone would be familiar with. But there are also autoimmune causes and drug-induced causes, all right? Now, in terms of hepatotoxic drugs, there is an extremely long list, of which this list itself isn't exhaustive, okay? So I suggest you have a read of hepatotoxic drugs in your own time to familiarize yourselves with as many drugs as possible. which is why most of these drugs require regular monitoring of liver function tests. So I think one of the most important ones is paracetamol, which would cause liver failure and cirrhosis in overdose, and then certain antibiotics, including treatment for tuberculosis, such as rifampicin, isoniazid, pyrazinamide. And then we have methotrexate in rheumatoid arthritis, and then statins, which require regular monitoring of LFTs. Okay. And of course, remember, the list goes on, okay? So have a look in your own time. Good. Now, we're going to start from the top of the alphabet and talk about hepatitis A. Hepatitis A is a non-enveloped single-stranded RNA virus, which is uncommon in the UK, but more common in the Indian continent, Africa, Far East, Middle East, and South and Central America. The incubation period is usually 2 to 6 weeks and is transmitted via the fecal-oral route, which means feces and feces-contaminated food and water. And then in terms of risk factors, obviously traveling to high-risk areas, and as well as being a man who has sex with other males, IV drug users, clotting factor disorders, and occupational risk. Okay, occupational risk being sewage workers who might be coming into contact with contaminated water and feces. In terms of presentation, there would first be a prodrome-like phase. So you have your flu-like symptoms, GI symptoms such as diarrhea, vomiting, nausea, and itching. But then we would progress to the icteric phase. So fatigue, anorexia, nausea, vomiting, and some signs of liver disease, which I've covered in the last part, okay? Bear in mind pale stools and dark urine, which will indicate a post-hepatic cause. And then we have the convalescent phase, which is malaise, anorexia, hepatitis, hepatic tenderness, and muscle tenderness as well. Okay, so the convalescent phase is the phase when the patient recovers from hepatitis, but this would last up to 6 months. Okay, in terms of investigations, we would do an LFT to have a look at the liver enzymes, which would be significantly increased in terms of ALT, AST, elevated bilirubin, as well, and elevated ALP and prothrombin. However, liver function tests are non-specific, so we would look to serology. So we would look to IgM and IgG. So if you're familiar with your immunology, you will remember that IgM is the antibody that's secreted first in an infection, which is why in an acute infection, you would have IgM, okay? If you have both positive IgM and IgG, then you have an acute infection. In a moderate amount of IgM and high IgG will indicate a recent past infection, okay? It's very unusual to have an isolated elevated IgM and negative IgG, which would indicate that there's probably a false positive. If you're immune to the infection because of a vaccine or a past infection, then you would have IgG but negative IgM. So just be sure to be aware of how to interpret some serology. Now, in terms of management, acute hepatitis infections are notifiable diseases, so you must contact the Public Health England and the local health protection unit. Unfortunately, we don't have any drugs to cure hepatitis A. We let the body's immune system function, so we provide supportive management and symptom relief. And analgesia, hydration, adequate bed rest. If the patient's acutely unwell, we would admit to the hospital, and of course, avoid alcohol and minimize contact with everyone to avoid spreading the disease, okay? And follow up to every 1 to 2 weeks. So that was hepatitis A, and for the remainder of this part, we're going to touch upon hepatitis B. Different from hepatitis A, hepatitis B is an enveloped DNA virus consisting of a core antigen and surface antigen, okay? And it is very rare in the UK. with chronic infections more common in places such as Southeast Asia, China, South Korea, and Sub-Saharan Africa. It has an incubation period of 40 to 160 days, okay? Now, hepatitis B is a sexually transmitted infection, so you would have sexual transmission. And in addition to that, you will have blood-to-blood, tattoo and piercings, and perinatal transmission, okay? However, transmission via breastfeeding is unlikely unless the nipple itself is bleeding or cracked. And therefore, risk factors would be a person being an IV drug user, having multiple sexual partners, being a male who has sex with male, traveling to high-risk areas, having blood transfusions, and also chronic renal failure, chronic liver disease, having occupational risk, or infants born to a positive mother. Now, in terms of presentation, just like hepatitis A, you would have a proton phrase, but this time it would be a fever, muscle pain, or a rash, and non-specific symptoms as well, such as nausea, fatigue, malaise, and other signs of liver failure, okay, or liver disease. But hepatitis B is different because it would cause extra liver diseases such as glomerulonephritis, vasculitis, and polyarteritis. I think this is a very important point to finish off this webinar, which is acute hepatitis B infection is asymptomatic in almost all infants and children, up to half of adults. So it could be a very insidious presentation. You just need to be aware of, okay? And in a chronic infection, there are often no physical signs, but there may be signs years later after the initial infection. So you need to be careful. Make sure you take a thorough history, and if you suspect hepatitis from the history, perform a serology or investigations. However, we will have to leave investigations and diagnoses and management for the next part, because this is coming to the end of this part of the webinar. This slide consists of the references used, and thank you very much for listening to this part of the webinar. That's it for this part, and if you have any questions or feedback, please email me, and be sure to tune into the next part, the final part of the webinar as well. Thank you very much.